with NOAF and organizing team for organizing such a beautiful conference. Very, very informative. I learned a lot. So the task for me is practical approach for subepithelial tumors. How should you go about them? So the learning objective for this is to discuss the common types of subepithelial lesions in the GI tract, what is the role of EUS in them, indications for histopathology, and how do you follow them up. So it's always good to learn from cases. So this is a typical patient which we see in our day-to-day practice, 60-year-old female, evaluated for abdominal pain, did a CT scan, you found a lesion on CT scan which is about 2.5 centimeter in the stomach. So what do we do? And as an endoscopist, we see that we see quite commonly subepithelial lesions in the GI tract whenever we do scopies, and it has been shown that the percentage of them is about 0.3 to 1% in various studies. So what should we be doing for this patient? Should we do a surveillance? You should do EUS, surgery, endoscopic resection. So GI epithelial lesions, about 50% of them are mesenchymal lesions. So they are schwannomas, GIST, neuromas, leiomyomas. And they are divided into benign, malignant, and potentially malignant. So malignant are clear-cut. They are less than 15% at presentation. So they are lymphomas, high-risk GIST, leiomyosarcoma, metastasis. Benign are much more common. They are lipomas, leiomyomas, pancreatic rest, and potentially malignant are GIST and NET. So we'll come to them soon. So it depends on where they are found during endoscopy. So 70% of esophageal tumors are leiomyomas. They could be, of course, varices, granular cell tumor. But in stomach, almost 2/3 of them are GIST. It could be heterotopic pancreas, carcinoid, and others. And duodenums are mainly carcinoid or Brunner's gland hyperplasia. So localization gives you a clue what it could be potentially. So this is the diagnostic algorithm for them. You do endoscopy, then you should be doing EUS and take a biopsy, but in which patient you should be doing this. So endoscopic assessment, the most important point here is that mucosa is completely normal, and these lesions are below the mucosa. So for lipoma, there's a traditionally described sign called as pillow sign, which is highly specific but low sensitivity. There is a depression or a dimple when you press it with biopsy forceps. And of course, the morphology gives us a clue what it could be for like pancreatic rest or something different. So endoscopic tissue biopsy is beyond the purview of this topic, but there are various ways. Sometimes it is done, but the results are very poor because mucosa is normal, as we know. So coming back to our case, it was 2 centimeter lesion, a firm nodular in the anterior wall of the stomach, not mobile, not pulsating, no ulcerations. So what we should be doing for this patient if it comes to you during endoscopy tomorrow? So of course, EUS is the diagnostic of choice, and the same has been given in various guidelines. As you can see, there are a plethora of guidelines for this lesion because it's quite common, and a lot of people have a confusion how to go about them. So EUS is very important modality in these patients, and those lesions which are arising from empilia, which are more than 2 centimeter, as per various guidelines, they should undergo EUS. And of course, you should need a sample from them, and FNB is the way to go. FNA with ROSE is also useful, but US FNB is the most common modality for them because FNA with ROSE is not available in all the institutes. So comparing CT with US, the difference in CT scan is it's very difficult to determine from which layer it is arising from because that is very important in managing these lesions. EUS can differentiate between intra and extramural lesion, and the sensitivity and specificity of EUS is almost 92 and 100% respectively for these lesions in telling us from where it is arising. So it is the investigation of choice in these patients. And all of us who do EUS, we know that we can see the lesions very well during EUS. So the role of EUS is in characterizing these lesions to define which layer it is arising from, to distinguish from intramural to extramural. You can exactly determine the size because sometimes what you see in endoscopy, if the lesion has an extramural component, it will be much bigger than what you see. So it will tell you to exact size of the lesion. You can make out whether it's solid or cystic. You can determine echogenicity, ecotexture, vascularity, lymphadenopathy, if there is any lymphadenopathy around it. And most important, you can acquire a tissue and send it to the histopathological examination. This is a busy slide, but it's quite simple in the sense in the EUS, we determine the lesion as anechoic, hypoechoic, and hyperechoic. So anechoic is completely black. So that means it's either a blood or a fluid. So if it's arising from the mucosa or submucosal layer, it could be varices, cyst lymphangioma, or lymphangiomas. So this clears what is anechoic. And the only hyperechoic lesion usually is lipoma. So if it is lipoma, it will be hyperechoic. Now we come to hypoechoic, which form the majority of the bulk of these tumors. So if it's arising from the mucosa or submucosa, it is either NET or malignant lymphoma. Ectopic pancreas is either in the submucosa or a part of muscularis propria. And bulk of lesions which are arising from the fourth layer, as we traditionally call it, they are GIST, leiomyomas, schwannomas. Another advantage of EUS is you can make out if the lesion is outside GI tract. So is it extra GI tract? Sometimes some organs, they compress and they give an impression that it is submucosal lesion. And you can very well differentiate it if it's any vessel or a tumor which is outside subserosa or serosa. You can make that out with EUS. GIST are very common lesions which we see in the stomach. And how do you differentiate between benign and malignant GIST? Of course, on endoscopy, ulceration is seen in malignant GIST, and EUS appearance, the benign GIST are smaller. They are less than 3 centimeters with smooth margins, round, homogeneous. These are gross criteria, and malignant GIST will be opposite to that. And presence of two of these criteria has almost 80 to 100% sensitivity in determining malignant potential of these lesions. And USFNA is very, very traditional, like how you do for any solid lesions. You follow the same principles. It is most, FNA used to be most popular modality, but the diagnostic accuracy is low. It can range from 40 to 80%. Because it gives a limited sample, and nowadays we need IHC in these patients, so sometimes it's difficult to determine mitotic index, and the pathologists want more sample. And fanning is very characteristic, like how you do for any solid organs. It gives a sample, better sample, but after fourth pass, there's a plateauing in that amount of tissue you get, because you get a lot of blood if you keep on continuing with it. So FNB needles are the way to go currently. These are they give you a core specimen, the whitish tissue, which you can do macroscopic examination, and main needles are Francine and Fock tape, and more and more needle keep on coming, and every year you see new needle coming, but these needles really have a good overall tissue yield when you use them. So this is a comparison, meta-analysis comparing FNA with FNB. And the odds ratio was 4, showing in favor of FNB. So it has established that FNB always gives you better tissue than FNAs. Bite on bite for endoscopic biopsy is much inferior. The yield is less than 30 to 40%, but FNB has a yield of almost reaching up to 90%. But lesions which are less than 20 millimeters, sometimes they are mobile, they are small, and there's not enough space for you to move the needle inside, so the yield can be less in them. AI is affecting our life in each and every way which we work and do. So it has also been shown to be useful in this when you do EUS, and it has been shown that the diagnostics with AI improves by almost 10% if you use some of the AI algorithms. Of course, it is still experimental and still not yet out for public use yet. And this is a busy slide mainly for pathologists, but grossly what we need to know that there are certain markers which can be done by the pathologist to help us distinguish what these submucosal tumor could be. These are actin, desmin, S100, CD117, complex names, but they can tell you what it is. Depending on that, they give the diagnosis whether it is GIST, leiomyomas, schwannomas, because that will decide us how to follow them up. Coming back to our case, it was a 2.5 by 2 centimeter lesion arising from MP, heterogeneous, well-defined, no lymph nodes. So the proposed algorithm for these lesions are they are usually diagnosed, as I told, either on endoscopy or a scan. EUS is the primary imaging modality, and then if it is lipoma or anechoic lesion, extraluminal lesion, you follow the another pathway for them. Hypoechoic lesion, less than 1 centimeter, they can follow it up without any intervention. If it is more than 1 centimeter, you should do FNA, of course. Expert like Dr. Puri can do even FNA for lesions which are less than 1 centimeter and give you the diagnosis, but it is not everybody's cup of tea. So if it's more than 1 centimeter, if it is GIST, they will go for either endoscopic or surgical resection. Leiomyomas, neurolomas, if they are less than 5 centimeter, you can follow them up unless they cause symptoms because of their size. Because if they are in the G junction, they can cause dysphagia, they can cause bleeding. So if they are symptomatic, then you have to resect them, otherwise they are benign. This is a busy slide, but this is a combination of all the guidelines which are there. So the color coding is for the guidelines which has come. So those lesions which are like arising from the submucosa, less than 2 centimeter, asymptomatic, either they can be resected or can be followed. If they are less than 2 centimeter as per ASG, they need EMR, but those who are more than 2 centimeter, they should either go for ESD or EMR. Gastric net, whatever is the size, it's better to resect them by whatever technique you can. Those lesions which are arising from muscularis propria, if they are asymptomatic, you do FNA and give us the histology, and depending on that, you can follow them up. If they are 20 to 40 millimeter symptomatic, you can do either ESD, STAR, EFTR, and those who are less than 2 centimeter, as per the ESG, they should be resected, or more than 4 centimeters, they should go for surgery. For the GIST, less than 2 centimeter, you can do surveillance or follow-up, but some of the guidelines says you should resect them. If more than 2, of course, they should go for resection either by endoscopy or surgery, depending on the expertise available. What about gastric net? What should be doing for them? So it has been shown that type 1 gastric net, their survival is same as that of general population. Local recurrence after EMR is about 60% in them. So this is an algorithm for gastric net. Those are the gastric lesions. If they are type 3, they should go for surgery or chemotherapy. If they are type 1 and 2, it depends on how big they are. If it is less than 1 centimeter, you can do endoscopic surveillance at 1 year. If they are more than 1 centimeter, less than 6, not involving muscularis propria, you can do endoscopic resection. If they are more than 6, involving muscularis propria, they should go for a local surgery or enterectomy. This is for the GIST, which are involving the muscularis propria. So it depends on the either what is the size of the lesion, what is the location, and what are the risk factors. Those who have risk factor, they should directly go for surgery. Those which are less than 1 centimeter, they should undergo surveillance. Those who are in the esophagus size 1 to 5 centimeter, other areas up to 3.5 centimeter, they can go for STIR procedures. So this is the surveillance, the last part of my talk. So ESG has given very good guidelines about surveillance for these lesions. So EGD should be done in 3 to 6 months for those lesions which are less than 10 millimeter in size, and then at 2 to 3 years interval. Those lesions which are 10 to 20 millimeter in size, it should be done at 1 to 2 years. For asymptomatic SELs which are more than 20 millimeter in size, that are not resected. So ESG says surveillance should be done for these lesions for EGD and EUS at 6 months and then at 6 to 12 months. They also say that those lesions which are less than 2 millimeter, with which you tried to determine the histology but you could not, you can resect them so that you don't have to do surveillance again and again. And this is what is depends on the expertise, what you can do, either STIR or endoscopic resection. So coming back to our case, we did FNA for it, 2 passes. It came as low-grade GIST, referred to surgery, but the surgeon sent it back to us for endoscopic resection. So my 2 cents of advice: most of SELs are asymptomatic and detected incidentally. History and thorough examination is very, very important for these lesions, like anything else in gastroenterology. EUS is the way to go. You should have a good EUS program so that you can do EUS can define the lesion from where it is arising, what is the characteristics of this lesion, whether they are anechoic, they are varices, there's lipoma, because you can leave them alone. And treatment can be based on the USFNA diagnosis, the size of the lesion, age of the patient, comorbidities, and it depends on the expertise available also. Upfront endoscopic resection is attractive, and as we have seen, endoscopic resection is getting more and more popular, and we have expert endoscopists who can resect them so they can avoid surgery. That's my family at work, and I invite all of you to be part of our yearly course, 18th and 19th September in Abu Dhabi, and registration is free for all those who come to ABIS meeting. Thank you.
So thank you so much, Dr. Yougsh. So we'll leave the questions at the end. I'd like to welcome our next speakers.